on, so that takes us to apologies. Do we have any apologies today we need to record?
Yes, Chair, I've got apologies from James Reader, Mark Burgess, Karen Watts and Michael Dennis.
Great, lovely. Thank you. Thanks, Sarah. Okay, any declarations beyond those that are already captured on the declarations of interest register? No, that's good. All good. Thank you. So that takes us to our minutes from our February meeting and the action log. As always, Sarah, a great set of minutes. Thank you. It was a packed meeting, wasn't it? So I'll just ask people, they've assuming you've had a chance to read them, are people happy to accept those as an accurate reflection of what we covered in that meeting? Excellent, good, okay, thank you. So that takes us to the action log, which from memory I think just had something on there that's coming later in the year in June, I think, Sadie. That was all, wasn't it?
Yes, that's right, yes.
Excellent, all right, we're happy to note that, that's good. Okay, so then looking ahead again, we've got this time 2 separate documents because we're obviously entering a new year. So we've got the today's items, which are on there, but maybe looking ahead, Sadie. So that's to reflect the new sort of pattern of meetings as well.
Yes, that's right. So we've tried to simplify the forward planner for next year to reflect the fact that we are sharing business across the 2 delivery groups and the committee, and to show the reduced number of meetings there. I would just point out to you all that we had got an extraordinary primary care committee meeting arranged for the 23rd of April, but that has now been moved to the 7th of May as a result of the pre-election period, which was announced towards the end of last week. And that will be a very focused meeting with only 2 or 3 items on it, unless things change between now and then.
Okay. All right, that's helpful, thank you. Okay, so let's move in then to the main items. So we start with the strategic workforce plan. So I think Jade is talking.
Would you like to do the risk register?
I forgot the risk. I've covered everything. Yes, I like the risk report. It's a good report. Yes, let's do that. Thank you, Sadie. Sorry.
Thank you, Debbie. So as usual, you've got the summary in front of you. Apologies that the last couple of boxes haven't been completed on that, but we will make sure that that is corrected and updated. Apologies, I missed that. There haven't been any changes in those scorings from memory, and they have all been to the delivery groups for review. So moving on to the 2 board assurance framework risks, if I can cover general practice and then I'll hand over to Fiona for dental. I'm taking the risk update as read. Just a couple of things to highlight. We have had an advisory audit, or we are in the middle of an advisory audit at the moment, and we have had a couple of recommendations, one for general practice, one for dental, as to little gaps in the control. So we are going to be adding into general practice the fact that we have a gap around the strategic framework, although you're all aware that we're working on that. And then in the dental risk, the dental strategy will move from a control to a gap until the point of of which we approve it. So just on general practice, the transition cover funding, we highlighted that about 38, I think from memory, practices have claimed that so far. The team has had a really concerted push on that, and those numbers are looking much higher now, so that's really good. I think it's really important to note the contract, the GP contract letter, as part of this risk, but we do have that later on the agenda. So I don't propose to go into any great detail on it now. And then also just to note that a progress update on the work we're doing around secondary care interface and the primary care access and recovery plan will be going to the March ICB board meeting on the 26th. And unfortunately, due to ongoing capacity issues, we haven't been able to bring a draft of that paper here, but we will circulate it offline at the end of the week for any final comments before it's published. We'll also be sharing it directly with the local medical committee for any comments that they have. So I just wanted to make you aware of that. I don't know if there are any comments or questions before we hand over to Fiona.
Okay, looks like that's okay. Thank you, Sadie.
Thank you.
Oh, wait a minute, I missed one. Peter.
Sorry. I guess it comes from an element of skin in the game, as it were. Obviously, we commissioned from primary care, Sadie. It's not meant to, it'll sound challenging, it's not meant to, but it's a genuine. On PC18, on the resilience in primary care, which is where my skin in the game is, I guess to some degree a similar question on dental, although I don't, commission directly. I'm conscious in primary care that the risk has been at 16 for what? Oh, I can't do math. 2, 4, 6, 8, 9. So about 21 consecutive months. And I just wonder, I just wonder whether either our tolerance should have adapted, because presumably it hasn't been realised in the 17 months, in the 20 odd months, if either our tolerance should have adapted or our mitigations, if they can be, need to be stepped up, because I just wonder what the trajectory looks like to resolve it. It was, and even actually I'm saying of those consecutive months, that's because you've kindly included the 22, 23, but in actual fact, the risk is logged as having been recognised, the primary care one, in 2020. And so I just, as I say, I just wonder whether to be fair to yourselves and the system, we should be maybe considering the lens with which we view it, because to some degree we've been successful in not having it come to pass, as it were. I hope I'm making some sense. Thanks.
No, you are, and I think it's a really good challenge. And in fact, we did have a discussion about the tolerated score in a previous discussion. So we've had the tolerated score at 12, which is actually quite high for a tolerated level of risk. But I think it absolutely reflects where we are. And you'll note from the dental risk that currently has a rating of 20, and that's been rated very highly for quite a long time too. I mentioned the GP contract, and I think we will have to watch this very carefully because of the funding increase that's being given to general practice in 2024-25, which will actually make it even more challenging for practices going forwards and their ongoing viability. So I don't think I've got an answer to your question. I would hate to think that we kind of normalise this level of resilience risk to our providers. But on the other hand, I think it's a very fair point that you raise.
Yeah, thanks, Sadie. I think Shepherd wanted to come in.
I just wanted to add on to what Sadie said. We've got a strategic resilience paper going to part 2 to have further discussions around this. So some of the issues may surface there and also direct us for the future.
Peter, did you want to come
So really quick, Shepherd, I wonder if we could pick it up after the meeting. I'm not invited into part 2, so I won't hear that discussion. So if maybe you and I could catch up separately, I'd be grateful. Thanks very much.
Great, thank you. Okay, so Fiona then, the dentistry one.
Thank you. I don't know whether Tricia wants to come in.
Sorry, I've
me.
missed a hand. Yeah, Trish, do come in.
I just wanted to apologise for arriving so late, but it was technical issues with my IT. Obviously, I am the Executive Director of Nursing, but Karen normally deputises for me at this meeting, but I'm pleased to be here today. But again, apologies, Debbie.
No problem. Thank you. Over to you, Fiona.
Thank you. So I will take the paper as read, and noting obviously the comment that Sadie made earlier. We're proposing to close the first 2 actions for September and December if the committee agree. In terms of the actions that have been completed, obviously the workforce plan for this year has been successful, and the UDA rate uplift has been completed with the investment agreed. Then moving on to the updates, I think you will note in here that we've added the National Dental Recovery Plan, and you will see the initiatives in there that are being proposed that we have details on so far. We are still waiting for details around some of the proposals to come through from the national team, but some of these proposals align with what the ICB has already been doing in terms of building resilience and trying to reduce risk. So we obviously will align our plans with the National Recovery Plan and adapt them accordingly to see. Sorry, excuse me. Which hopefully will help to improve resilience in primary care. Our survey has closed with over 2,000 responses, and we are currently evaluating them, and that will help to inform our long-term plan. And then we've just added an update about the urgent treatment service, and you can see the data there for the first 3 months of the service. So that's the data from November through to the end of January, with over 5,000 patients being seen. And we're running at an average of around, I suppose 1,700 to 1,800 appointments every month. It's too soon at the moment to say whether that's having an effect on the rest of our system in terms of ED and NHS 111, but obviously we'll continue to monitor that. A report was taken to our delivery group in March around the urgent treatment service as to date. Just to respond to Peter's question around risk, I think for dentistry, we've only had responsibility for just under a year. I think the risks are still high, and until we start seeing some of the work that we're doing to help build capacity, support workforce retention, and improve access, I think that dentistry will remain high, but obviously we'll take it away in light of your comments, Peter, and have a think about it.
Thanks,
And I'm happy to take questions.
Any questions for Fiona? Fine.
Thanks, Fiona. Very useful update, and I do like sort of these little data points on urgent treatment service and the good response rate you seem to have had on the engagement process. And it led me to a question, and maybe you're already planning this, but when the committee looks at the long-term dental plan proposal early May, could you also include sort of our experience with the short-term plan over the past year, because I'm sure it will help inform the long-term plan. It's good to take that into account. And the other request related to Peter's early question is with looking at the long-term dental plan early May, let's have a good look at the risk, whether we're satisfied with the tolerated level and the risk scoring. Thanks.
Thanks, Hein. I think that's a good
Thank
idea.
you.
I wonder if I might just have a couple of questions. So I realise I don't know the sort of the geographic spread of those urgent treatment services. Roughly how many places?
Yes, we've got 23 providers, and they are across the whole of Norfolk and Waveney.
Okay.
It would be fair to say that some areas are more highly populated than others, but we have got a good spread. Yes.
Okay, thank you. And then my sort of 2 penneth worth on the risk thing is going to be, and maybe you could just take this away and have a think about it, is whether, so I like the idea of having a sort of a more detailed look at it in May, as Hein suggested. I wonder whether it might be, as part of that, perhaps suggest some of the key sort of milestones which might be key sort of steps on bringing the risk down. So if we had X, we feel we would be likely to, we don't have to hold ourselves to it, but what the significant sort of shifts or changes might be that would bring that down. Maybe see if that's something like that is possible, I guess, be helpful. Okay, excellent. All right, so let's move on then. I've got far too many screens and documents open here. So that takes us to where I thought we were, which is Jade on the strategic work plan. I think I saw Jade pop up a minute ago.
Hello, thank you. I'll take the paper as read, but I just wanted to highlight a couple of key points for today. The main feature I wanted to talk about is in relation to GP retention. If you haven't seen, Norfolk and Waveney has been highlighted as turning our retention figures around to retaining our GPs within the area. The HSJ interviewed me last week, to put a spotlight on Norfolk and Waveney. So under 40 GPs years old, we're second in the country now. And then for all overall GPs age demographics, we're fourth in the country. So that's a really big turnaround from the position that we were in the last 12 months. And this has led to a lot of the programs that are featured in Appendix A, which highlights all the programs work. So they're all contributing factors in terms of our retention. The other targets I wanted to talk about is obviously the wider footprint. So all the programs that we provide support for cover general practice, dental and pharmacy. At this stage, we haven't got optometry due to the funding position that we're currently in, but there are 45 programs linked to workforce recruitment and retention, and also training and educational pathways. Pleased to note that obviously all those programs are in progress or have been delivered. 8 of the programs are actually above trajectory, 19 being met, and 17 are currently in progress, as we've got a number of KPIs linked to those individual programs, and one of them haven't been fully reached at this point. There was one program that we are unable to deliver, which was the Higher Development Board, due to the take up from primary care colleagues. They weren't in a position to take on that program in that financial year. The other element I wanted to talk about was obviously the external funding bidding awards. So we were very lucky in receiving over 100,000 from a national program for Norfolk and Waveney to pilot a enhanced generalist school program, which is linked to our coastal and rural program of work. We've obviously also received 16,000 in external funding for diabetes and foot screening programs, and we've submitted as of this week over 92,000 in terms of some apprenticeship work, looking at dental, and also supporting our community pharmacy colleagues, and we're waiting on a decision from that early April. So that is the current position, and happy to answer any questions.
Okay, that's great. That's impressive, in success in those bids. Actually, it's really, really good. Trish.
So I've Chair, I've complimented Jade and the team before, but I just like, as it's unusual for me to be at this meeting, to actually compliment the team again with regards to their endeavours. The amount of work, the bids that are happening, the support that's being provided is absolutely second to none. And I hope that the practices really value you as much as we do within the ICB. I'm absolutely sure they must do. My question, however, is about the interoperability with the workforce initiative in our system in totality. So when I think about the work in the coastal communities and the niche work being led by UEA, when I think about all of the workforce plans that are being led through our acute and community providers, I suppose what I'm asking, Jade, is are they benefiting from your success and expertise in taking some of their plans forward?
Yes, so thank you, Tricia. So a lot of the programs that we are doing, because my team is now sitting under the People Directorate, because previously we were in the Primary Care Directorate. That's really opened up the opportunities for primary care to be exposed to system-wide programs and initiatives. So I'm very much front and centre supporting primary care, making sure primary care are being represented at those levels. So a lot of the work we can talk about, for example, the top slicing process. There's a really good example where we're working as a system to look at our CPD, our training and educational pathways, and doing that collectively. The coastal and rural piece of work, we're working with our voluntary sector organisations, for example, to do that volunteer to career pathway. So a lot of the programs we're implementing are working either at a system level to make sure primary care is represented, or we're also onboarding to making sure that we can get other system partners involved with the work that we're doing. But we'll continue to drive that forward within any external funding bids that we're doing. And part of the process is obviously to outline how we're integrating within the system for these national programs and how we can support primary care as a whole.
Thank you so much.
Thank you. I've got Hyde, then Hilary.
Yeah, Jay, let me first add the compliments, Tricia, pay to you and the team, so well done. My question is, are you happy, satisfied on the awareness of the programs in the field, whether it's primary care, dentistry, pharmacy, etc., or are there pockets where the news has not reached of the availability of some of these programs?
That's an area of work that I would still like to expand on. We are currently building, with the support of our digital colleagues, a single point platform. That is an area that we haven't been able to fully deliver, and that's one of the KPIs that we haven't fully delivered that, and that's what's referenced in the appendix. So once we have got that single point of platform available, which we're hoping digital might be able to start doing that in the ICS space from April, then I think that will be far wider reaching all the programs. But what we do in the meantime is we obviously attend practice managers meetings, we go to primary care networks, we're engaging with the LDC, obviously also all the local committees to make them aware in our various channels. But I think the digital platform is our next phase, Hein, and that's where we'd like to get to.
Yeah, thank you.
Thank you. I think it's Hilary next.
Hi, sorry, I've got issues with Teams and no camera working at the moment, so sorry about that. I mean, it's obviously good news, but it doesn't feel like it's that good out in general practice, I have to say. Recruitment is still really quite challenging, and although there are some new people around, I think there are a lot of practices still carrying quite a lot of vacancies, and that kind of feeds into the resilience conversation that we had a little bit earlier. So I was a bit curious from the numbers as to how much of the increase are doctors in training, because I know that they've been trying to increase significantly the number of trainee GPs, which will obviously help in the future, but maybe not straight away. And what's the trajectory looking like for people retiring? Because I know, certainly looking at practices that I know well across the patch, there's a lot of people who are approaching retirement age and who are looking at things like the new contract letter that's just come out and thinking, actually, that's not really a very positive reason to continue. So I just wondered, what's underlying some of those numbers? How much of it is trainees? What are we looking at in the future? What does it kind of really look like out on the ground, so to speak?
Yes, certainly. So if I just go to my other paper, it does provide me with some figures in terms of the risk register, and I've just done that. So just bear with me for one moment while I pull that down. But we certainly have seen an increase in all staff numbers. Let's have a look. It's been 158 whole-time equivalents as we've seen an increase from this point in comparison to last year. And I will just get the risk number. So if we break it down by GPs in particular, just to give you we've actually had a 2.5% growth increase of GPs, which excludes training GPs. There has been a 9.8% growth in GP trainees in comparison. We've got a slight decline in our nursing numbers of 0.1 in comparison to this time last year. We now have a dashboard in place to look at all the demographics. So it's looking at the age demographics, looking at the trajectory plans. And I've been working obviously with business and intelligence, and also Charlotte, who does our workforce planning trajectory on behalf of the system, and working with system partners. So it does look like there is going to be an increase in GP trainees for Norfolk and Waveney over the next few years, looking at the forecasts that are coming through from NHS England. But there is a small decline in nursing staff, and I'm looking to investigate that further to understand the leavers rates, particularly with our nursing, and looking at with our legacy nurses. So we are looking to develop some further programs to support that and bring some people in to give us additional support as a system in terms of that.
Thanks, Jade. Trish?
So Jade, with regards to those endeavours to think about the recruitment and retention of nursing colleagues, of course this is something that's high on my list and my priorities. So let's keep close and work on that together, because I think it will fit in beautifully with the chief nursing portfolios and the work streams there. Thank you.
No problem. Thank you. I will do.
Andrew?
Sorry, did you say me?
Yes, I did. Sorry,
yeah,
Andrew, go.
Missed you, sorry. I just wanted to contribute because I speak to people on behalf of Healthwatch, and was standing outside a surgery in South Norfolk last week. And what people crave is stability in their clinicians. They want to see the same GP, the same practice nurse, and so on, long term. So the part that follows from that is, underneath those numbers, Jade, is there any way of telling the stability of the workforce? Because I get the impression from doing appraisals that an awful lot of our younger colleagues want to do locum posts or maybe work for the out of hours system once they're qualified as GPs, but they don't want to do the perhaps traditional route of staying in a practice long term. But that's just my impression. I haven't got any figures to back that up, but that's just conversations.
Yeah, so one of the programs we have introduced over the last 12 months is to look at our ST3s. So obviously when they're qualified to become into salary positions. And that is probably one of the triggers of why we're now second in the country of retaining them, because we've had a big increase in securing our ST3s into the system. Absolutely, I think we know that they've got some elements in terms of additional sessions. So through locuming, we've got a program in place where it allows people to do that flexible staff pool model where they can locum, but also it is also supporting them to be salary positions within primary care as a result. I can unpick it further, but our locum numbers seem to be quite steady across Norfolk and Waveney. There hasn't been a huge increase. We have seen an increase in salaried roles. But we also have seen we need to look at the head count in comparison to the flexible hours as well, the flexible working arrangements that we've got. Norfolk and Waveney, from the primary care survey that we took part in nationally, flexible working model was our #1 highest contributing factor in favour of how we're benefiting. So I just need to look at the head count comparison to whole time equivalent. So I'll look at that further and come back, Andrew, and see if that's made a change at all.
Yeah, brilliant. Thanks.
Just before I bring Hilary in, what's ST3?
That's when in the final years of training to become a fully qualified GP at the end of it, once they've got their qualification. So it's in their last final year. They do 12 months in primary care.
Okay, thank you, Jade. Hilary.
So maybe a slightly different way of looking at it. Do we have any idea from practices how many vacancies they're carrying, or if there was a GP available to appoint, how many would they appoint? Because it does feel like the numbers are obviously going up, which is great, and that's really positive. But it doesn't feel like, you know, the kind of question Andrew was asking. It doesn't feel like that need is being met somehow. So I just wonder what the gap is really, and whether it's worth asking the question the other way around.
Yeah, absolutely. We are looking at vacancy levels across the system, with particularly in primary care. We've got that in dentistry. We know what the vacancy position are in dentistry, so we need to pick up the same piece of work within general practice. So we'll be looking to build that in as far as that. So we'll be building that in for my next year's programs of work as part of our training needs analysis to make sure that we're capturing what our current vacancy levels are as a system.
Thank you, Jade. We love a bit of data, don't we? As soon as you give us a bit of data, we want more and more. And I can see everybody's eyes lighting up about, you know, your dashboard and everything. And maybe, you know, you've given us a taster today. So it'd be great at some point to come back with a more sort of, you know, fuller picture. I think we'd get a lot from that. I was also just going to ask, do you do any more sort of, you know, I suppose interviews, semi-structured interviews, research with GPs and ST3s and all those things you've talked about, almost as well as the sort of the hard numbers, to get some sort of, you know, qualitative stuff from them about, you know, what drives them, what you know keeps them here, why they don't, that sort of stuff. Do you ever get the opportunity to do any of that?
Yeah, absolutely. With the programs we put in place, we do a lot of research. So effectively, we're working with practices to understand what will keep them in the area, what will be an attracting piece. So a lot of the programs we co-design with a practice, and we pilot it and we test it out, and then we evaluate. So as I said, a number of the programs we've put in place this year, we're in that evaluation stage. So we're working through, has it delivered what we wanted to deliver in terms of the trajectory, but also what are the other changes that we could make in the new year as a result. So absolutely, we look at that. We also have within my team, we have a number of fellowships in place, and one of those fellowship is looking at workforce recruitment and retention. So they're helping us support those programs and designing particularly around our models of GP retention programs, anything from newly qualified right up to the sort of mid post year, end of year development. So yeah, we've certainly got certain programs in place, and also we do that quantitative measurement as well with practices and also with those individuals, particularly those that are about to qualify, what they want to keep in. We've done a lot of that work with our newly foundation dentists, our therapists, so really to understand what are the drivers for them to keep them Norfolk and Waveney, and what would help them in their pathway for their professional development as well.
Okay, that's great. Thank you. Okay. So a really helpful discussion there. Thank you. And some really great questions. So I think we're noting this. This is sort of an update progress report. So yeah, so thank you. Thanks very much, Jade. That's really good. Thank you. Okay. So then we do come to the GP contract. So Sadie, this is yourself?
Yes. The covering paper is short and sweet, just pulling out some of the key points. And I think it is really important that we recognise the funding uplift that has been provided. it is disappointing for general practice. We know that nationally there is currently a referendum underway through the British Medical Association, and I think Ian, I can see on the screen, will know far more about it than I do. But there's a simple question: do you accept it or don't you accept it? And then the outcome of that will lead to, I would imagine, further discussion about what happens next. From a resilience point of view, bearing in mind our resilience risk for general practice, we already know that some of our practices are experiencing viability issues, particularly those that are reliant on more locum staff. Some practices already telling us that their salaried GPs are earning the same or more than their partners, which is a disincentive, quite obviously, to remaining as a partner running a practice. And we know that costs continue to rise. So we are watching this very carefully. We will be wanting to see what comes out of the referendum. I think we should note the potential for increasing resilience risk in general practice as a result. And of course, this is all in the context of a much wider, challenging financial picture for us as a system, which provides us with limited scope to support financially. I suppose if to focus on some of the more positive aspects of the letter, I think there has been an effort to recognise some of the feedback that's been received nationally, and I can certainly reflect in here some of the feedback that I've been providing based on the comments I've been getting both from the LMC and from local practices. So there is a desire here to try and simplify and reduce bureaucracy, but it is probably, I would say, not felt to be enough out there in general practice to counteract the disappointing financial uplift in the contract. So I probably won't say anything more than that. I'll take the rest of the paper and the letter itself as read, but happy to take any comments or questions, Debbie. You were muted, Debbie.
Apologies, I've got a cold and I'm sniffing and coughing, and so I turn it off in between so you don't hear that. And then anyway, Ian.
Thank you, Chair. Thank you, Sadie. I think it's as a brief overview, very helpful to share the paper that you've pulled together. So thank you for that. Just to reinforce your comments, really. Yeah, it is disappointing. Who knows where this is going? But again, picking up on positives, I think you've highlighted the first one in your first bullet point about reducing bureaucracy. That is to be welcomed at whatever level. It's also for the ICB to play its part in reducing bureaucracy in general practice, and I think that's an ask that I would put to the meeting today. We do need a strong general practice. You'll be aware that over 90% of all the contacts within the NHS are undertaken by general practice. It is the front door for the whole system. And without an effective front door, a front door that is struggling to meet patient needs, then the whole system struggles. So I'm not going to teach the meeting how to suck eggs, but just to reinforce the points that you make in the paper, Sadie, it is a very crucial year for general practice. Who knows where the election is going to take things, but irrespective of that, in the interim, each one of us on the meeting today has a part to play in trying to shore up general practice and reduce bureaucracy. So thank you.
Thanks, Ian. Hilary.
Hi, thanks. I think overall there's a huge level of disappointment. There was a BMA webinar one of the evenings last week. I tried to join and never got onto it because it was so busy. I think there's a huge level of frustration, anger. I don't know what the right word is really in the profession at the moment, because I don't think, the 2% just does not recognise what's going on in primary care. There are significant increases in staff costs that occurred last year, and we were part of a multiple year pay deal then, so nothing could be done about that, and then people were waiting to have that kind of sorted out this year, and then for it to be 2%, and there's increased staff costs again this year with the change in living wage and all of those things, so everybody ends up going up a bit. So I think it's just really misjudged where things are at in primary care, this letter. I think, nationally people are really frustrated. I think also I've never known it so bad in terms of work from other sectors landing it in primary care at the moment. So although there's loads of good work going on around interface and we're all trying very hard to resolve some of these things, it just seems to have got really a lot worse in the last few weeks and months. So I think there is a real level of kind of frustration and worry about how things will go forward. At the end, people will have to look at their staffing and look at their resources if the 2% stays as it is. I'm hopeful that they'll look at it again and realise that was not the right answer and come back with something different before it gets any further, but only time will tell.
Okay, thanks, Hilary. Anybody else? Any reflections? It's a difficult time in the political cycle as well, isn't it? As you come to the end of one sort of, lifetime into another. It's a transition time between, elections and everything. It's a tricky time, I think. I think public services are feeling that. Okay, so it is what it is, and we watch this space, but equally, the work that we continue to do here around the resilience of general practice becomes, ever more important, really, and just reinforces, doubling down on the work that we are doing. Okay, we'll move on. Thank you. So now we come to dental clawback and the repayment policy. I've probably got something open that tells me who I should be coming to, but if you shout, then... Hey, there we go. Excellent.
So, my name's Matthew Lewis. I'm a primary care finance officer at the Norfolk and Waveney ICB.
Great.
I'll take the paper as read, but I'll provide a little context. The dental contracts, as they are currently modelled, are paid upfront at 100% of their value. Where a contract has not performed 100% of their value, at the end of the year, the shortfall of their performance is clawed back around 6 months after that period. These repayments to the ICB are usually taken over 3 months, which is the BSA standard. But for some of our providers, that is far too short of a period and can cause them some significant cash flow problems. One way of mitigating this cash flow risk is to allow those repayments to be extended beyond that 3-month period. To be clear, this isn't reducing the shortfall. Where they haven't achieved 100%, that will still need to be repaid to the ICB, but the length of time over which that is paid can be changed. We never inherited a policy from NHS England after delegation, so we've drafted this policy and are hoping to get it approved, where we've attempted to standardise the process so that any decisions that we make are fair and will be based on the request's merit itself. So if I could ask the committee to approve the policy and welcome any questions. I know Stuart is also here, so if anyone's got any queries, thank you.
Okay, thanks, Matthew. That's very clear. Full disclosure here, I I haven't read every single word of the policy, so just give me the headlines of actually what it says in there, and how you're approaching this. I understand the concept and everything, but how are you actually going to judge it then?
So the it's an exceptional circumstance. Yep. So we would expect that to be an exceptional circumstance highlighted, and we would also expect providers or the practices to provide us with their proposed repayment policy. We won't be preparing cash flow statements or anything. This is for them to come back to us and say what. And alongside that, we've tried to create the process whereby how the decisions can be made, what information we consider if we were to reject a policy, a request. We need to know what those reasons are in advance, so that we can build a framework so that we can ask the right questions, such as what is their current year performance? If it's halfway through the year and they're missing targets, then it might expose us to a much longer financial risk if we allow an extension to their debt. Yeah. So it is to mitigate that financial risk whilst also ensuring that service and provision is maintained, so that we don't get caught up on finance assurance but also on service delivery. So it's trying to manage those two objectives.
Okay, that's really helpful, thank you. Fiona.
Yes, I think I was just going to add to what Matthew has said. This is really about trying to get the balance right between financial and commissioning risk and supporting the resilience and stability of our dental practices. And this is a part of the plan that we're developing for around year end, to try and get that balance of supporting our practices whilst obviously retaining financial responsibility for the monies. And as Matthew said, this would be used in exceptional circumstances, so it's not something that we would want to apply across the board. And obviously we would have to look very carefully on a case-by-case basis.
But it provides that sort of, clear framework in which to do that, which is very important. Hein.
Yeah, thanks, Matthew. I'm supportive of the policy, and it's good to have one. I guess my request is, say, in a year's time, to have a bit of a look back, see how the policy has worked out. Did we get 10 or 30 requests? Did we approve half of them? Just to get a feel, because it gives also us as a committee a look into resilience, I think. Thanks.
Yep. Thanks, Hein. Nick.
Good afternoon, everybody. I'm the newly appointed dental advisor to this committee, so it's nice to be here amongst you. I just want to reiterate Fiona's views that we have to be treading lightly. The situation in dental general practice is incredibly fragile at the moment. I won't need to draw your attention to the fact that it's been across the newspapers and the media that NHS dentistry is struggling. We had hoped that the delivery plan, recovery plan, was going to be a game changer, but in truth it hasn't. And the risk then, this is the point I wanted to come to, is that very often some of the practices that are faced with clawback coming out of the lockdown situation, is quite frightening. And for many of them, if they are looking at other colleagues who have handed back their contract, there is a risk that this could happen. And I'm not saying it's going to happen in every case, but when you're faced with huge amounts of clawback money over a very short period of time, some colleagues could be seeing potential bankruptcy. And for them, it will be, well, in that case, I'm going to go private. So I think this policy, Matthew, that you've pointed out is a really sensible one, that if we can use a situation where we can mitigate, instead of taking money back over 3 months and risk losing the contract altogether, to say, let's take it over 6 months. And one of the things is the strategic importance of the practice is one of the points that you could use as exceptional risk. And I would say that's something that you should focus attention on in order to avoid our colleagues handing back the contract, either in total or in part. So thanks very much for letting me speak.
That's really helpful, Nick. Thank you. Thank you. I think am I right in thinking that any clawback is retained by the ICB? It doesn't disappear back up to NHS England. Is that right?
But the current year policy is that we retain underperformances as an ICB. However, that it can be subject to change depending on NHS England. So it's not something that we can automatically assume, but it is the current process.
Stephen.
Yes, thanks. Just for 24-25, just to further Matthew's comments, 24-25 planning guidance does state that it wouldn't be retained by the ICB. Any funding would be clawed back by NHSE.
Or 24-20 next year.
Next financial year from April 1st onwards, yeah.
Right. It's just such a challenging area, isn't it? And I think we're right in this committee to highlight that important balance between, not on the one hand having a policy that ends up sort of almost going against the very thing we're trying to do. So I think, we're right to have a policy that is well balanced in that way. And it's also, I still think it's a tricky one to get across publicly. There's money that is there for dentistry, but hasn't then been spent, and it just sends all the wrong messages when everything we're doing is trying to rectify that. So it is a challenging area. Hopefully it's a transitional place, and this time next year we'll be in a stronger position. Okay, any other reflections or comments for Matthew? Okay, all right, so we're happy to agree this policy. I take it's for us to agree. Yes, it is. Yeah. Yes, nods. Marvellous. All right, thank you. That's great, thank you. Okay, and then we're coming to what I think are refreshed terms of references for the committee and for the groups as well. Am I right? Yes.
Yes.
Okay.
Thank you, Debbie. So obviously we've been, as of last year, we obviously updated the terms of reference to reflect expanded responsibilities for the Primary Care Commissioning Committee for all 4 primary care services. And we've taken the opportunity to look back as to how the governance framework through the committee and the delivery groups has been working. And we are proposing to make actually what are some quite minor changes to the committee terms of reference, but some changes to the GP delivery group. The main aim really is to allow the Primary Care Committee to have much more time for strategic oversight and delivery of the assurance role under delegation agreement, and to allow time for planning and deep dives. We're proposing at the moment that the committee meets quarterly, although we are very conscious that we need to look at this very carefully in the coming months to ensure there are enough meetings to take place to allow the committee to exercise its responsibilities. One change that we are proposing in light of the strategic oversight is to invite colleagues from Healthwatch and representatives from the Health and Wellbeing Board and local authority colleagues to join part 2. So they will be there for the whole meeting. In terms of the delivery group, I'll take the paper as read, but just to highlight a couple of points. The committee chair and vice chair will be invited to attend delivery group meetings. And the main changes are to the general practice delivery group to extend its responsibilities and remit to include community pharmacy. Obviously, the synergies between community pharmacy and general practice will hopefully ensure a close working relationship between what goes on in those areas, and obviously a much more integrated approach to bringing those two together. I also just wanted to raise a couple of points that came out of the advisory audit, which Sadie referred to, which we're currently going through. Where they've recommended that we clarify a couple of areas for the terms of reference. One is to give explicit oversight of the primary care strategic framework within the committee terms of reference. And the second one is to expand on the wording around the committee's responsibility for quality and safety. It is there in the delegation agreement, and it is there within the terms of reference. But the advice has been whether we lift some of the wording from the quality and safety committee and bring that into the primary care terms of reference. So it links into primary care responsibilities. And also we believe that it would be helpful to put an extra term in each of the delivery group terms of reference to make it explicit that issues can be escalated to primary care committee where appropriate. So apologies that those weren't included in the paper, but hopefully they're acceptable. If agreed by committee today, it will go, the terms of reference will go to the board at the end of this month for approval.
Okay. Peter.
Thanks. I'm happy to be told there's not the space for this in this meeting and to pick it up outside, but just on the local authority point. So on one side of the same coin, there's a bit for me of testing what of this needs to reflect the position around the wider ICS. So obviously the local authority commissions explicit services that are public health funded from the same set of providers. I recognise proportionately it's very small scale, but not only is it important to us, I would suggest it's important to the ICS if we think about prevention and such. And my second side of that same coin is, and actually in some, and again, proportionately it's small scale, we are commissioning directly on behalf of the ICB for some of that primary care activity. And I'm conscious that we've never really resolved where we sort of sit in membership of this group. I don't come to part B. There was a sort of period of time when my position wasn't invited here. And now there's this idea of this meeting will meet less frequently. We've got the delivery group that's forming. And so, yeah, I just invite a bit of thinking and reflection on what, if any, whether it's the one side and our responsibilities, or the second side, those that we enact for yourselves, for the ICB, you know, what if anything, in terms of formal membership or representation we feel we should have. Thanks.
Thanks, Peter. Trish.
So, obviously Karen normally attends this meeting, Chair, and has my delegated accountability for decisions. I am just struggling a little bit in having not had enough time to think through the quality elements and the codependencies between this forum and the Quality Safety Committee for the ICB, which is focused on a complete overview of quality across our whole system. If this meeting is to become less frequent and the only quality oversight is through this forum, then I think that inherently holds a risk. So I would ask, depending on the outcome of other conversations, that I just have a little bit more of an opportunity to think that through, to ensure that we are providing the oversight, but also the support to primary care in the same way as we do to all other provider organisations. I'm sorry if that delays the process, Debbie.
No, I think that's well made, Trish, and I suppose to some extent as well, it's a bit about what is covered as well in quality terms at delivery groups. I'm suggesting as well, which do continue to meet in between and at the same time. So I don't know the fit there. I wonder whether it might be possible for Sadie and Fiona to have a discussion with you offline, Trish, and work through and map it through. And if there is a need to, adjust it and make a change, then Hein and I can perhaps meet offline and do that on behalf of the board. Is that reasonable, Sadie? That's safe?
Yeah, yes. So I mean, I think it's a really good challenge, and certainly thinking back to when we originally drafted the terms of reference, when we had co-commissioning, our Director of Corporate Governance was really keen to reflect that link with the overall quality approach, recognising that delegation includes the responsibility for primary care quality to this forum, and hence why she was very clear that she wanted Tricia or a nominated deputy to be a voting member of the group, so that we had that link. But I think we could strengthen that link, and I would be really pleased to take that offline and talk about it, and then we can perhaps circulate an updated version. We've got about a week to do that if we're going to make the board papers.
But it is loads of time.
Okay, all right, that's helpful. And in terms of sort of Peter's question around public health, sort of as a commissioner of the local authority and commissioning on behalf of the ICB as well as on behalf of the council, again, maybe perhaps, Sadie, you and I could have a catch up with Peter, and we could work through how we might ensure that we're picking up this through both the delivery groups and this committee as well.
Absolutely, and I think we've tried to reflect how important that link is through the committee. There, I was just trying to double check and remind myself. I'm not sure that the membership extends to the delivery group. I'm just looking at Fiona, and that might be a bit of an oversight on our behalf. Actually, I would be really keen to catch up to talk about how we feed some of that, recognising your comments about working as a system, getting better integrated and so on. I'd really welcome us to join up more around how we reflect the whole of commissioning from general practice, so that we can consider how we include that better in future. That'd be really helpful.
Yeah. Okay. All right. That's good. Thank you. I mean, I guess we are still, finding the right balance of all these things as we go forward, aren't we? And testing. And I think one of the strengths is that, as a group, we're ready to sort of adjust and learn without sort of flitting. But I think, it's important that we get these things right and test it. If it's not working, we try something else. So that's helpful. Hilary.
Yeah, I was just going to say I've just got a degree of nervousness that as we've said before, most consultations occur in primary care. There's a huge agenda of things that need to change, need to happen in primary care around, and it's just where some of that is going to sit, and are we going to have the capacity and capabilities to do that if we make meetings less frequent, and also the transparency around, what the discussions are around that. So I suppose I've not really got it clear in my head that we'll be able to do that well from what I've seen.
Okay, I mean, I think the intention behind this is to allow this committee to keep an oversight on the more strategic issues, whereas the delivery groups, deal more with the operational stuff and escalate through there. But I think we need to keep asking ourselves and challenge about whether this committee then has the capacity to be able to fulfil that strategic sort of oversight and drive that is required, given, as Hilary and others have said, about the sort of transformation and the issues facing general practice. I think that's the challenge for us to keep our minds on. Sadie.
Yeah, thank you. I think just looking back to when the ICB was formed, we were very keen to continue to meet in public with this committee meeting, although there is no requirement for that through the delegation agreement, but we were very keen to maintain that. And we've also, since we've implemented the delivery groups, we've ensured that we bring a report from those delivery groups to each meeting, and then that flows through from the committee to the board meetings when they meet as well. So we are really keen to maintain that transparency and to find ways of managing the workload. I think we are very conscious that there's a huge amount going on, and to run committees and delivery groups at every month is just it's a lot of work for the team, quite honestly. Servicing 3 sort of 3-hour meetings every month, and then all the papers, and trying to get the work done as well. So I would be very grateful if we could kind of see how it goes. We're not wedded to it, so if it needs to be tweaked as we go, then we're very, very happy to do that. But this was an attempt at trying to find the best way to manage the responsibilities, manage the workload, and remain as transparent as we possibly can.
Yeah. Okay. That's right, Sadie. That was the bit that I forgot, wasn't it? Because we did, there is doing the work in between as well as having the meetings, really. Okay, so I think we're sort of agreeing these, but with the conversation around the quality and ensuring that we're tight on that. And also, notwithstanding, the legitimate concerns about whether this gives us enough time and capacity as a committee to deal with the things we want to do. But for now, we're going to try it, but we're going to monitor it tightly. And if we need to adjust it again, then we come back and we do that. Okay, great. All right. Thank you, colleagues. Thank you. Okay, so that does take us then to the delivery group reports. General practice and dentistry. So general practice first.
Yeah, so if I may pick that one up, yep. Debbie. So this is a report of the meeting that was held on the 20th of February, which was quorate. I will take the paper as read, but would just like to highlight a couple of areas, if I may. So firstly, we received another CQC report from the Stalham Stayth practice, and that had been rated as good, which is fantastic news. And actually, just in the last day, we've had another practice rated as good following a recent inspection, which will be taken to the next delivery group. I think what I'm really pleased about with this is not just a reflection of the hard work that the individual practices have put in, but I think we're starting to see a bit of rebalancing. We were very concerned probably a year or so ago that many of the CQC ratings were coming out as requires improvement or inadequate following inspection, and that seems to have actually balanced the other way now. And the more recently we've been seeing more good ratings, and I mean, firstly, it's an acknowledgement of the hard work that practices are putting in, but I think also we should probably note the amount of support that the ICB teams have been providing, particularly through quality and medicines management in a proactive way. And I know this was something that the LMC were very keen on. The LMC has also appointed its own resilience officer, and I have no doubt that that's having a positive impact as well with that support that's available. So I thought that was a good point to highlight. Secondly, we are continuing to see the resilience and capacity issues in general practice impacting on the uptake of our health check programme, so particularly learning disability health checks and severe mental illness health checks. And we continue to look at the numbers and the action plans in great detail. The severe mental illness SMI health check target has significantly increased for next year to 75%, albeit that there has been a register change in that, which is reducing the size of the register by about 14%, I think, and we need to work through and understand that a little better. But I think, looking forward to next year, particularly in the light of the conversations we've had around resilience issues and contract funding, etc., I think there is a really significant risk around that 75% target. We are currently, our initial submission is likely to be more around the 60% target, a 60% uptake, because there is no more funding at the moment to invest in that, and there is likely no more capacity in general practice to invest in that. But this is the very first submission, so we will have to continue to work on that and see where we can go. The third point that I just wanted to highlight was we have had 2 approvals at the meeting to progress to the next stage of premises development for Orchard Surgery in Dereham and for Cutlers Hill Surgery in Halesworth. So they will no doubt be reported on an ongoing basis through Paul Hyam's premises update that he brings regularly to committee. Yeah, it's really good news that we can see the estates continuing to be developed in primary care. Happy to take any comments or questions, Debbie. You're muted.
Yeah.
Sorry, go Hein.
Yeah. Thanks, Sadie. The SMI register change is an interesting one because I read in the write-up clinicians are concerned. So I guess you could say 40% reduction, it might be easier to reach a target, but the percentage is going up. But is it right by the 14% that are no longer on the register? I think that's the bigger question. I think sometimes we're so keen on reaching a target, we sometimes forget what we're doing it for. So I'm just interested. You said more will unfold and it's going to be followed up, but any immediate reaction to why they're no longer deemed on the register? What is triggering that?
I might ask Shepherd to interject if I may.
Yeah, thank you. I think when we got the update at the ODG, we didn't have enough information, and information is now surfaced, and it's not as we were concerned at the time. I think the big concern at the time was people with severe enduring mental illness, schizophrenia, will be removed from the register, but that is not correct. The adjustments that are being done are to do with patients on lithium, but with no diagnosis of mental illness, and those will not be included, and that is correct to do.
Thank you.
Thanks, Shepherd. Okay. Hilary.
Sorry, I'm a bit confused as to why somebody would be on lithium if they don't have a diagnosis. I just wonder how good the coding is. It is a nightmare trying to get coding absolutely perfect, as I think everybody would appreciate. So I just wonder, is there any work going on to look at those patients to see if they should have a diagnosis and they should therefore still be on the register?
It's a national process at the moment, so there is a lot of work going on to actually get those registers right. But what we know is we have seen a significant reduction in the patient numbers because of some of the proposed changes. We'll have to update that as we work through the new reporting.
So I know with regards to SMI health checks, which are probably so important for those individuals with the comorbidities, but just going back to the LD health checks, Shepherd. So we've done a lot of work in year to improve the uptake. How confident are you that we'll achieve the 75% target by the end of Q4? And what more could this committee do to support you in that endeavour if your belief is that it's not going to be hit?
It's going to be a close call, Tricia. I think in the last 8 weeks, we have provided almost over 50 clinics additional capacity and to help practices. As of today, we also received a practice asking for support with complex cases for home visiting. I think it's fair to say that the territory where we are now is really around complex cases that we have not been able to reach through a standard way of doing annual health checks. And we've got clinical capacity via NNN through the reservist that are supporting to reach out to more complex cases, and also from fens and breaks, which is really fantastic. I'm positive that we should be able to hit that. But having said that, I think we have noticed the level or the rate of DNAs going up. And this morning we've been talking with the quality team to follow up on some of the cases that are being reported by practices. So it's going to be really, really a close call as it stands. I think it's fair to say, I think as of January, we were at about 54%, and that should rise by almost 10% by end of February. That leaves us with 15% to cover in March, which we've got the capacity to do, but other factors may play in, but we're watching closely.
Hilary?
Sorry, can we have a conversation offline, Shepherd, maybe about the lithium? Because I'm worried that I'm not reassured by the fact that it's a national process. That makes me probably more worried rather than less worried. And I just think if we've got patients currently on lithium who don't have a diagnosis, we probably should be talking to our practices about making sure the coding is right for those patients rather than just accepting that they're taken off. So maybe we have a conversation offline about it. Thanks.
Absolutely.
Yeah, thanks, Hilary. I think that'd be helpful. Okay, that's good. So, Fiona, we're coming to you for the dentistry one.
Hi,
yeah,
Debbie.
Will's going to do this.
Oh,
Thanks,
sorry.
Fiona.
Apologies.
No worries, Debbie. Yeah, it's William Lee, Senior Primary Care Commissioning Manager for Dental. Good afternoon, everyone. I'll take the paper as read, but provide a brief overview for the operational group that was held on the 8th of February for noting purposes. A short-term extension to the out-of-hours service until the end of 2024 was approved to give time to review the current service and consider a longer-term procurement. A paper was approved relating to a contractor requesting a permanent increase in their UDAs with the aim to provide stability and resilience to this provider. The group reviewed 2 papers together as they were both of similar requests, that of UDA reductions. Both of these papers were approved with the ICB offering support from our workforce team. Since the group met, one of the providers has reversed their request to reduce their UDAs. A presentation was received from the workforce team. It included information on the primary care dental workforce and retention programs and their target achievements thus far. The presentation received positive feedback from the group. The group also received a presentation on the 5-year long-term dental plan, where it highlighted in the next 2 years the ICB aims to support increased access by focusing on 3 key areas that are improving access and addressing health inequalities, empowering and supporting our local population, and building capacity to improve recruitment and retention on our dental workforce. The group were informed that a survey was published between January and February, which gave the public and key stakeholders an opportunity to give feedback on the priorities in the long-term plan. That item is the single item for escalation to committee, that the feedback from those surveys is to be taken to the PCCC once evaluated. The meeting was quorate and attendance list is included in the report. Thank you, Debbie.
Lovely, thanks, William. Anything else anybody wanted to ask or add to that? No? Okay, that's great. Thank you very much. Okay. So that takes us to the prescribing report. So this is. So is Michael?
We've got Jessica. Debbie.
It's myself, yeah.
Okay.
Okay.
Thank you.
Thank you, Debbie.
I don't just randomly say names, just to reassure you.
That's absolutely fine. So, hello everyone, I'm Jessica Adcock representing Michael Dennis today, and I'm the Head of Pharmacy and Meds Optimisation at the ICB. So I will take the report as read. However, I just wanted to highlight that in the first section of our report, we have a number of strategic priorities that we've been mandated by NHS England to work on. The ones that relate to primary care are addressing problematic polypharmacy, addressing low priority prescribing, and improving valproate safety. So we will include these in our future reports to update the committee. Are there any comments or questions on our latest report?
Maybe while people are gathering, I was interested in the I can't remember what they're called now, the reviews, the medication reviews. So that was in the context of polypharmacy, which I'm assuming is where you have lots of different drugs for lots of different things.
That is correct, yeah. So I mean, we used to say that polypharmacy was more than 4 drugs, but now we say it's more than 10, more than 15 drugs. So it's very complicated patients with multiple comorbidities.
So can you just say a little bit about what those structured medication reviews look like, what they achieve, and then I'll bring Trish in.
Yeah, so structured medication reviews are carried out by a clinical pharmacist in general practice. So they are reviewing the whole patient and all their medications. They're not taking one particular condition and ignoring everything else. It's a holistic review with the patient, and then that clinical pharmacist will then refer into either secondary care or the patient's GP, depending on the outcomes of that structured review.
Okay, thank you. Trish.
And the reviews are generally very well evaluated by individual patients who have them. And as we know, one of the biggest reasons why people are admitted into hospital are as a result of falls, which often are related to polypharmacy. So therefore, it's a fantastic thing to do. I just wanted to go to point 4.2 of the report with regards to the work that's going on with regards to antibacterial prescribing. I've recently taken over the chairmanship of the stewardship group, and I'm really pleased to note that with the support from the team that we're now starting to see a downward trend in prescribing, which is an excellent way forward. So I'd just like the committee to note that. Thank you.
And Tricia, we're in conversation with Naomi Fleming, who's the regional antimicrobial stewardship pharmacist, and we're going to be putting on an event for West Norfolk, where antimicrobial prescribing is higher than the rest of Norfolk, to help to support change in prescribing behaviours in that area of the county.
Thank you.
Hilary.
Yeah, so I just wanted to flag an area of risk is always when people's meds change. And so people go into hospital, they come out of hospital on new drugs and they sometimes don't know what they're for. Or sometimes, as we've been finding recently, they're taking the old drugs and the new drugs and hadn't realised they're meant to have stopped the old drugs. So I just wondered, with the drive to obviously improve the speed of discharge and make sure that people are flowing through the acute sector in a speedy way, I'm just a bit concerned we seem to be seeing more risk in terms of handover of medication and people's awareness of what they should be doing. I just wondered if that is being flagged anywhere or whether it could be flagged somewhere.
It is. So I hope you're aware of the discharge medicine service, which is a service whereas when patients are discharged from hospital, their discharge medication summary is sent to their community pharmacy, where the community pharmacist is responsible for reviewing and identifying exactly what you have just pointed out, and then working with the patient to make sure that their medication is taken safely and appropriately. This has been raised with Frankie Swords directly because at the moment there isn't capacity in our trusts for staff to actually send these discharge summaries out. So we are looking at another East of England trust where they're doing this digitally, so we can try and get this implemented more appropriately within the Norfolk and Waveney area.
So Jessica, if I'm a patient and I'm in hospital and I've gone into hospital, you know, maybe having some medication.
Yeah.
Something happens to me in hospital, I get treated, and I'm discharged home with some more medication.
Yes.
What you're saying is that it's the onus on the hospital to send something to the community pharmacist who's part of the primary care team. And then it's their job to get in touch and say, okay, so are you sure what you should be taking? Do you understand this? Is that it?
That is the new service, yes. At the moment, unfortunately, the onus still sits with the primary care general practice team because that isn't happening routinely. Yes.
Okay, Hilary.
Yeah, that was going to be my question. Do we know if community pharmacy's got the capacity and do we know the numbers? Because it doesn't seem to be happening at the moment from my experience.
See, Tony's here.
Yeah, go on, Tony.
The answer is it's an essential service, so we will have to find capacity for it. So if those referrals come through, we are contractually obliged to do so. Part of the problem at the moment is that we are getting literally a small handful through from each trust, which is a percentage of discharges is infinitesimal. So it's not actually become business as usual in our pharmacies. So that if we do need to sort of ramp up that, and the hospitals manage to ramp up those discharges, we do need to do another piece of work with our pharmacies, reminding them of that service and the processes involved, etc. Because since we launched it in a big fanfare about sort of 18 months ago, possibly 2 years ago now, they've actually seen very little of the service, and frankly, a lot of them will have forgotten about it. So it is an important service, not just because the pharmacies may well have old medication or non-relevant medication still on the shelf and nobody tells us anything whatsoever. So it is a massive area of risk that there is a good service for, and it is just how we find other parts of the country have managed to make it work better in the trust. So we do need to look at where it is working. Obviously we've got workforce issues worse than everybody else here, but is that just the excuse that such a major item, which is nice guidance and everything else, should be allowed to just drift untackled? And so far it has been for the last sort of 18 months or so.
Okay, thanks, Tony. Trish.
So this is a really helpful conversation, actually, with regards to improving the experience of individuals at the point of discharge. So if I think about our discharge position now in comparison to 12 months ago, we are seeing more people being discharged in a more timely way and their length of stay reducing. We've done a lot of work on actually making sure that they take their medications away with them when they're at the point of discharge. But the whole issue of how do we as a system provoke concordance with that medication, I think is probably the bit that is missing. So I thank Hilary for raising it in this forum, and I think this has to be captured as an action so that we can go away and think about how we can do it most effectively for the benefits of our community pharmacists, but also, of course, most importantly, the patients and the families. So Jessica, I'd be more than happy to work with you and Frankie and Michael around this.
Thank you. Be really helpful.
Good. Okay. Anything else anybody wanted to ask Jessica about the prescribing report? No? Okay, all right. Well, that was a helpful discussion, Jessica. Thank you. It probably wasn't where you thought it was going to go, but hey ho.
No, but really helpful.
Really
It's good
good.
to hear
All right.
people's points of view. Thank you.
Okay, thank you. Excellent. All right. And so we come to the finance report. Is this James?
It is. Thank
you,
Debbie. So as usual in the finance update, I'll treat the report as read, but just point out the key updates. So as we move into month 10 of the financial year, the ICB is currently forecasting to underspend by £14.3 million across the prescribing, primary care, dental, optom and pharmacy areas for the full year. This is a small movement from month 9 reporting numbers and has worsened in month by £500,000. This can be predominantly attributed to a worsening GP prescribing position. The financial summary shows the total overspend broken down, but there are 5 key areas of variance that are shown in those individual subdirectorate pages. Firstly, the GP prescribing currently showing £5.3 million overspent, a £0.7 million worsening from month 9. Majority of this is due to the key prescribing cost pressures of SGLT2, CGM and DOACs, and a temporary reduction in our largest rebate for edoxaban. There are also pressures within oxygen costs and some slippages in our efficiency schemes that are baked into our budgets already. Second area is within delegated co-commissioning. There's now an underspend there once the LCS offset has been factored in. It's due to additional recurrent allocation being awarded in month 6, plus some non-recurrent prior year releases. Third area being dental, showing an underspend due to multiple factors. Firstly, due to the handing back or reduction of some current year dental contracts, creating a positive variance against budget. Secondly, due to the performance adjustments now being recognised for 23-24, clawback due to the reduced activity. These are partly offset by new investments in emergency and children's pathways, workforce initiatives, and some UDA uplifts and reviews. Fourth area is optom. There's been additional activity in here, which has been driven by the availability of resource from national chains of optometrists and their ability to flex it locally. And then the fifth area, pharmacy, again, additional activity specifically in advanced services that can be offered. We're still pursuing some additional allocation for this, but this is not yet being factored into the forecast. Other areas to point out is the Section 90 efficiencies update. This shows an update up to month 10. We're showing £0.7 million underachievement against the planned efficiencies, which represents 6.7% of the total planned efficiency. The pod scheme being the largest area of slippage. And then the final section there on the LCS activity, we've received up to date of the paper being written. This does highlight the areas where we have less activity than planned for. So mental health, SMI health checks, care homes, eating disorders and inclusion health being the ones most underachieving. So that was all I was going to point out if there are any questions at all.
Any questions or comments? Hein.
No, it's really common. Well captured, James. So there's 2 clear pressure points: the GP prescribing, as you say, but dentistry in an interesting way. And I know we've touched upon it, although it's financially a help, it's actually a huge pressure point. And
absolutely
slightly concerned with what Stephen was saying earlier in the call on any unspent money's no longer within our own gift next year. But well captured. Thanks, James.
Anything else? No. It's always, I'm sort of torn away because, you know, underspends are great in one way, but on the other hand, you know, actually the money is there to be spent on the services that are required, and if you're not able to do that, then there's something in there. But equally, I can see the sort of the pluses and minuses in there, but I guess, you know, it is the dentistry one that stands out, really, doesn't it? Okay. All right. Okay, well, that's very clear. And do we get month 11, or do you go straight to end of year, James?
It'll be
period 11.
I think we'll probably for the next update will be end of year. I think we'll have depending on the timings, but I think that'll be correct. Yeah.
Okay, thank you, Hilary.
Sorry, quick question. The care home thing that's underspent is do we know why that is? Has anybody looked into that? Because I was thinking that was based on the number of care home beds, I think, and care homes are quite a intensive work kind of resource use for practices. So I just wondered, really see that underspent is a bit of a shame. I just wondered if what had happened.
We do have some practices that may be late in claiming for those. You're right, that the care home beds is kind of set on the number of beds that each practice is kind of responsible for, so should be pretty much to plan. But I suspect in that area it is just a lag in the claims, and we can keep an eye on that just to make sure that there's nobody that's not claiming for something. If there was a particular practice that wasn't coming up, we would try and make contact and say, you know, why are you not claiming? So.
Okay, all right, that's good, thank you. Any other business? I don't think there is any, and I'm not aware of any questions from the public that have been sent to us. Sadie, is that right?
We did have a question, Debbie. It wasn't relating to an item on the agenda, and we have responded to that offline.
Okay.
We will ensure it's published if it hasn't already been on the website.
Marvellous. All right. Okay. Mindful of what we said about there's likely to be an additional meeting coming up before June. That's right, isn't it? But so we'll circulate and notify about that. Otherwise, the next one is on June the 11th. Okay, all right. Well, thank you very much. And part 2 will start. What time are we starting part 2?
Suggest 20 past.
20 past.
20 past. Marvellous. All right. Okay. Thank you very much, everybody. Thank you.
Thank you.
Bye.